have to rotate the lower leg until the plane between the two malleoli is parallel with the image receptor. So you're going to do a slight rotation of the leg. It's usually about 5 degrees, usually. So we're going to rotate the in medially just slightly. We're going to use an image receptor. Are we doing tabletop or bucky? Why are we doing tabletop?
Less than 10 centimeters.
Less than 10 centimeters. Okay, so we're going to do tabletop. We don't need a grid for this.
Is knee and up, right? You go into the grid.
Yeah. Knee and up, you're gonna. That's where you knee, either grid or
But femur and
tabletop.
up.
Okay, but once you go above that, then you can start using
Unless
it.
it's a big leg. So
Unless it's a big leg, right? So again, 10 centimeters is going to be your guideline. Okay. Lower leg. Lower leg, we usually don't use. We usually don't use the grid. Remember, it's the bone that we're looking at. So even if it's a big leg, the bone is still the same. So basically, we're just shooting through muscle and fat with a bigger leg.
So the inflammation doesn't affect.
Usually, it does not. Okay, so you're still going to be. Your kVs are not set in stone, so you can always fluctuate between 5 to 10 kV either way. Okay, but it's still not thick enough for us to use a grid. All right. So tabletop. You want to include both joints, ankle and knee joint. You need to include both joints. Typically what you would do is, because of the lower leg, in your book it shows you going from one edge to the other edge. Okay? But you may not be able to include the entire leg in there, so what we'll do is we'll change or rotate the image receptor so we're going from corner to corner to include the entire leg on the image receptor. Okay? Now, if you have problems getting the entire leg on the image receptor, on your first image, on the 14 by 17, you would include the part of interest. Okay? Lower leg, you say, okay, it's my ankle that I hurt. So you're going to include the ankle, but you're going to omit the knee. Again, this applies to if you can't get the entire leg on the image receptor. So you will take on the larger film to include the ankle, and you will take a separate shot of the knee. Now, how about if the injury of interest was towards the knee? Well, now I would include the knee and take take the ankle on another shot.
But if you could fit both joints on one, then you just fit them on one.
Right. If you can fit them both on one, then that's great. But a lot of times you can't. Okay, so you include the part of interest on the larger film and then the other part on a smaller film. Okay? So central ray for an AP leg is going to be on the mid leg, slightly rotated. You're going to use a shield. Okay, always shield your patients. Use the marker on the lateral side of the extremity. Collimate tightly, because we're talking about large leg. Your Tibfib is not going to change. This is just all muscle and fat. So you can collimate tightly, and you can skim or cut part of the soft tissue out.
So we're not looking at the shadows, basically, or?
You're still looking at the shadow, but I don't need to be opening way up here because this is just muscle and fat. I can go tighter because the bone is going to be centralized. I don't need the tissue.
So if you cut off some of that soft tissue, it's not a big deal.
It's okay. Okay? So the entire Tibfib is going to be demonstrated to include both your knee joint and your ankle joint. There's going to be partial superimposition of the fibula and tibia at the proximal and distal ends. Partial superimposition. All right? Any questions on the AP? So this is the importance of demonstrating both joints. Okay? You want to include both joints, and if you can't, again, you take the part of interest on the larger image receptor and the part that's not of interest on a smaller image receptor. Okay? But you want to include both joints. Medial lateral. Same thing applies here. Try to get them on a 14 by 17. If you can't get it that way, from end to end, then turn the image receptor so you're now corner to corner. Place their leg on top of the image receptor. They're going to be rolling up on their side. Okay? Laying on the table on your side isn't comfortable, so you want to make them as comfortable as possible by using different types of cushions and positioning blocks. You're going to feel for the epicondyles. We want the epicondyles what? Perpendicular to the image receptor. So we're feeling for the epicondyles. We're making sure that the plane between the two malleoli are also perpendicular to the image receptor. This is what gets us on a true lateral. Okay, so you're feeling for the epicondyles, you're feeling for the malleoli. Okay? Same thing applies here. If you can't get everything on one image receptor, take the part of interest on the larger and then the other one on smaller image receptor. Such a ray is going to be directed mid-leg. Okay? So the entire Tibfib is also demonstrated, including both joints. The proximal head of the fibula is superimposed by the tibia. Highlight that. The proximal head of the fibula is superimposed by the tibia. And then the distal part, distal fibula, is also superimposed over the posterior half of the tibia. Okay, so again, it's the distal and proximal ends that are going to be superimposed. You guys don't have this. I started putting some more interesting pictures up. Okay. So same leg. Is there any issues here? Okay, these are all different patients. Okay, but here's one. What do we have a fracture of here?
Tibia.
Now, when we have a patient who has injury, because we'll talk about trauma radiographs again later on. When we have trauma injuries, are you going to have the patient flop their leg around to try to get that view? Okay, so if you can't, how are we going to get a lateral? If they can't roll on their side, if you can't turn their leg, how are we going to get a lateral? We say horizontal, okay? So you're going to be thinkers when you go out in the field. A lot of the things that you will see will not be textbook. So you should be able to make those adjustments when necessary, especially when you're doing trauma and surgery type of procedures. All right? So this is probably done cross-table. This, I don't know what happened here. Okay, what do we have? What did they break here? Huh? Okay. So this is obvious, right? So they broke the fibula here. And also, you can see the break right here, the tibia, right? So they put rods and screws to stabilize that. I mean, they put that rod all the way up the shaft. Okay, so I don't know what's going up there. Maybe there may be some additional injuries that resulted in having the rod extend from the bottom to the top. Okay, here we have one of another patient. Probably went through the ER. They said, you know what, we need to cast this first and keep you stable before we take you to surgery. So they put on a cast. Now, where's the other part of the fibula?
It's on the other
Well, it's
side.
way over here. It's pushed in into the tibia. Yeah. All right. The knee. All right. So the basic views of the knees is going to be 3 views because it's a joint. We'll be doing an AP, an oblique, and then a lateral. AP, oblique, and a lateral. What are they doing now with the knee? Are they using tabletop or what? Now they're using Bucky. Okay, so they're going to use a Bucky grid because the part is generally greater than 10 centimeters. It cleans up the images. It's going to be less gray, more contrast, more black and white. Okay? All right. So your tibial plateau, central ray is going to be directed to the tibial plateau. How do we find the tibial plateau or that joint space? Remember that palpable body part? What is it? The patella. So now we're going to go a half an inch below the patella to get us into that knee joint. Same thing applies. We're going to feel for the epicondyles to make sure that they are parallel with the image receptor. You may have to roll the ankle a little bit medially to put the leg in a true AP. True AP means in a relaxed position. You guys have laid down before. Where do your legs like to flop? Towards the side, okay? So when you plop off the side, you want to roll it up until the patella, which you can see and feel, is right at the very top. Rotating it until the AP is right at the very top of the view. Okay? You don't need a large image receptor, so image receptor 10 by 12. Collimate accordingly. Now here's the nuance, guys. Your angulation is going to be based on body part thickness. What body part are we talking about? We're talking about the butte. Okay, the booty. Okay? Because the thickness of the booty will change the opening or the space between the femur and the tibia. So this is the way it's going to work. Average size, 19 to 24 centimeters. Well, how are we going to measure this?
Eyeball it.
With your hands.
Hey, you're about 19.
We're going to try to use calipers, all right? So we're measuring the distance between,
She got all that
between the as is and the backside, okay? So average 19 to 24, X-ray tube is going to be perpendicular, okay?
So you know when you get those freaks with like alien booties, it's just still 5 degrees, it doesn't get any bigger than that.
Say that again?
The alien
If the butt exceeds 25 centimeters, it's still
like a Kardashian.
Oh, like a
It's
Kardashian,
excessively
okay.
big.
Right.
So would the angle
Or
go above
Beyonce.
5 degrees, or is it just a 5 degree?
You're going to start off about 5 degrees. So I mean, yeah,
Nicki Minaj.
25.
Yeah.
Yeah,
That's
you're
excessively
right.
big.
Right. I think there's going to be a play of about 5 to 6 centimeters. So anything greater than that, then you may have to start angling more.
Like you're getting a
I
40
know, I
degree.
agree with you. Yeah, I get it. Okay. All right. So if you're 25 or greater, you're going to angle 5 degrees towards the head. Okay. If you are less than 18 centimeters, okay, now you're going the other way, 5 degrees caudally. Okay. Are those the other freaks?
The long backs.
The long
Pancake butt.
Okay. So 19 to 24 average, greater than 25, 5 degrees up, less than 18, 5 degrees down. All right? Any questions? I'm sorry, I just had a picture in my head. All right, so here's your AP knee. The femoral tibial joints are going to be open. Again, it's an angulation that's going to open up the joint space. And notice here also that the patella is smack dab in the middle. So rotate the leg accordingly so the patella is right in the middle. Not off to the side, but right in the middle. Can you guys see the patella?
Mm-hmm.
Yes.
You guys can see it now. Remember 2 months ago? You guys probably couldn't even see the patella. Okay, I keep bringing this up because I'm very impressed with the way you guys are progressing. I really am, so I'm proud of you guys. All right. The knee joint is going to be centered, small collimation field. You're going to have slight superimposition of the head and the apex. The head and the apex behind the tibia. All right? Any questions here? Moving right along. Yep. AP lateral.
Just throw a Band-Aid on it.
I figured I'd make this more interesting because the pictures that we have in the book, it doesn't do you any justice. So I'm showing you some pretty cool stuff that you will probably be seeing out in the field. Okay. You can see that injury, but you can also see some soft tissue and also soft tissue injury here and some swelling due to the trauma.
So is that a compound fracture? Did it go through?
It's a comminuted compound. You've got some transfers. You've got some obliques.
You got them all,
You've got a
bro.
whole bunch of stuff going on.
You hit everyone. Good job,
Yeah,
dude.
you also got some trauma. You also got some trauma going on.
Right.
You're not seeing. Yeah. All right, AP medial oblique. This is going to be the most common type of oblique that you will do for the knees. Okay, you have an oblique, but the most common is medial, and you're going to rotate the knee 45 degrees. What are we feeling for here?
Epicondyles.
The epicondyles. So you feel for the epicondyles, rotate the leg at 45 degrees. But you can also see what the patella is. Okay, so the patella is not neither here nor here, it's in between. That will also give you 45 degrees. Okay? The patella will be your bony landmark that you feel for, and it's going to be about 1/2 inch below that. That'll take you to the knee joint. Okay? Here's the other oblique that we don't commonly do. So it's just the opposite oblique at 45 degrees. Again, feeling for the epicondyles, 1/2 inch below the apex of the patella. So what's the difference between the two? Okay, medial oblique. Medial oblique, okay, the patella is going to be over the medial side, exposing the lateral aspect of the joint. Okay, so when you hear medial oblique, patella is going to go over the medial side, okay, revealing the lateral side. So patella is over the medial condyle. Proximal Tibfib joint is going to be open, and the lateral condyles of the femur and tibia are well demonstrated. In the lateral oblique, look what happens with the lateral oblique. It's kind of doing, remember this with the forearm? Okay, where the bones start to cross? In the lateral oblique, the bones start to cross. So now you have superimposition of the fibula over the tibia. The patella is going to be over the lateral condyle on the lateral oblique. The tibia superimposed over the fibula, and then the medial condyle and the medial condyle of the femur and tibia are demonstrated. Okay? So again, this is why this is more and more common, because it avoids any type of superimposition. Now, some facilities will say, okay, their basic views will include both this oblique. But so far, everybody that I've talked to, they have the three basic positions, which is the AP projection, medial oblique, and then the lateral. All right. Here we have now the medial lateral. Medial lateral. So a couple of things are happening over here. So first we're going to roll a patient up on their side. You're only going to flex their knee approximately 20 to 30 degrees. Flexion of approximately 20 to 30 degrees. More flexion may close the patellofemoral joint and also separate fragments if there is any injury to the patella. So 20 to 30 degrees is what is necessary. Now, when you are doing a medial lateral projection, they're on their side. Again, make them comfortable. Put padding under their leg. We're feeling for the epicondyle so that it's perpendicular. Your central ray now is, remember how you have the angulation of the joint space. We're going to angle 5 to 7 degrees towards the head to open up that joint space. What's also going to happen here is because the medial condyle, this medial condyle is lower than the lateral condyle, this angulation puts superimposition on those two condyles. So two things are happening here with a 5 to 7 degree angulation. It's going to open up the joint space, number one, and number two, it's going to superimpose the condyles. Okay. Central ray is 1 inch distal to the medial epicondyle. But when you're looking at this, isn't it also about 1/2 inch below the patella? Right? So now let me ask you this. So in a non-trauma, we're going to roll our patient on their side, and this is a medial lateral projection. What happens if the patient is a trauma patient, and now we have to do a horizontal beam?
Lateral medial.
Okay, it's lateral medial, but what are we going to do with our tube angle? We're going the opposite way, yeah. So now we're going to go towards the feet about 5 to 7 degrees. to open up that joint space. That is one of the biggest problems that techs, I'm not just talking students, I'm talking about techs now, the problem that they have today, is that when you get a trauma patient and they're shooting this cross-table lateral, they do perpendicular. And they forget that the angle changes from medial lateral to lateral medial, and so they'll do a cephalic angle shooting it this way. All that does is close the space up even more. So you have to do the opposite. Same thing when you're operating a C-arm in surgery. You got to remember, depending on where your X-ray tube is, okay, if it's going lateral medial, you got to angle it towards the feet. If the X-ray tube for the C-arm is going medial lateral, you got to angle it towards the head. And they can't figure out why they can't open up that joint space. Okay, you guys remember that. Medial lateral towards the head, lateral medial towards the feet. Okay, so this is what it looks like. So it's opening up the joint space. This is how it's not supposed to look. Joint space is closed. Medial condyle is lower. So what we want to do is we want to superimpose the two condyles and open up the joint space. Now, this is also important that I want you guys to make note of, is when placing the patient on their side, there's a possibility of over or under rotating the leg. If it's over rotated, what will happen is there's going to be less superimposition of the fibular head. So in other words, this joint space, see there's some superimposition there? This is proper rotation. If it's over rotated, this will be free from superimposition. If it's under rotated, there's going to be more superimposition of the fibular head. Did I say that right? Less rotation, no superimposition. Okay, over rotation, more superimposition. So we're looking at this. The fibular head is right here.
So that's under rotated, right?
Is it over or under rotated?
Under rotated.
It is under rotated. Okay, you guys have this? I think this is going to be a great test question. Just saying. Just saying. I just like to say stuff. Okay, weight bearing knees. Okay, a lot of injury that happens to the knee, a lot of wear and tear. Okay, overactivity. So weight bearing, patient standing up. We're going to put the placing the body. Our central ray is going to be directed where?
1 inch below.
All the knees are the same, so it's going to be about a half an inch below the patella, but we're doing bilateral for comparison, so it's going to be between the two knee joints. All right, so AP, your central ray is perpendicular. Now, when we're doing PA, this is what happens. The toe, your feet, is going to cause OID when you're standing up straight. So when standing up straight, your knee is going to be far from the image receptor. So we want to get the knee as close to the image receptor as possible, and that's accomplished by bending the leg and placing the knee right on top of the table or closest to the image receptor. Because of that bend, we have to apply a 10 to 15 degree caudal angle. Which of the two views do you think is better, AP or PA? Okay. PA would be better because you're putting the part closest to the image receptor, but in practicality, which one are we going to do? This is probably more practical to do. Yes?
For the PA, do they bend until they physically touch it?
Right, so they bend until they physically touch it. And that's why you have that range of 10 to 15 degrees.
So we do both, or you do one or the other?
You do one or the other.
Oh, okay.
It's only one or the other. Okay? So the knee joint is centered to the collimation field with no rotation of the knees. So the joint space should be open. So again, this is to evaluate the joint space. Probably looking at the cruciate, not the cruciate, the meniscus to see if there's any type of compression or any type of damage to that area. Okay. All right. Moving on. The intercondylar fossa. You guys remember the intercondylar fossa? This is the backside of the femur. That area right there. Here is a superior look of that fossa. Okay, back, superior. So what we're doing here is we're trying to open up that fossa and to evaluate that space. Again, these are studies to evaluate the ligament or the joint space between the tibia and the femur. These are going to be common views that you will be doing in radiology. So it looks funny, but you guys will be doing this as a common view. Okay. So the first one here is the Camp Coventry. Okay, Camp Coventry. Patient is on their belly. They're not using the bucky, but you should be using the bucky. Okay, because we're dealing with a body part greater than 10 centimeters, right? So patient is on their belly. We're going to prop their lower leg up to form at least about a 45 degree angulation. Okay, that's your average, 45 degrees. Okay, on their belly, leg topped up about 45 degrees. Central ray is going to be directed at the popliteal crease. Okay, you can see the crease of where you bend leg bends at the back. And it's going to be perpendicular to the lower leg. So it's perpendicular to this leg. This is the Holmblad method. You can call it whatever you want. Holmblad method, okay? On their knees, on all fours, okay? Now we're going to have them lean forward. From this, you're going to lean forward about 20 to 30 degrees. Center ray is going to be what? Just like in the previous image, it's going to be perpendicular to the lower leg, centered at the crease. Okay, so that's the Holmblad method. Here is the apiaxial, also known as the Beclair method. Leg is flexed approximately 40 to 45 degrees. Center ray is what? Perpendicular to the lower leg. These are all methods to demonstrate the intercondylar fossa. So they did this by placing the image receptor as close to the body part as possible, but we still have OID. Also, the problem with this is because of this angulation, the fossa is going to be demonstrated somewhere here at the edge of the cassette. So we're getting close to cutting that off. It's not going to be in the center. It's going to be somewhere here off the edge. So this is a tough projection to do. They use a curved cassette, which reduces the OID, and it's a lot better than a square cassette. So you won't be seeing this as much. But is it still done? Yes, it's still done.
So because of the OID, would you not bring the tube down to compensate for the angle? And because
of the OID, no, you want to bring it up.
That's
You
what
have
I'm,
OID, yes.
so that's what I'm saying. You wouldn't bring it down to adjust it, right? You kind of can leave it at 40.
Yes. Well, no, you should
Or
bring
you
it up just
bring
a
it up
little
even
bit.
higher?
Yeah, 'cause
Okay.
Again, if you don't obtain that 40-inch SID, okay, again, your radiograph is going to look good. But because you are still close, you're giving the patient more exposure. So you got to adjust your distance for that. Does that make sense?
I'm talking about magnification though, because of the OID.
Oh, magnification, yes. So magnification, you still want to bring your tube up.
Okay.
Yeah. Right. Okay. Then you got this. And you got this. Okay. Final result here is demonstration of the intercondylar fossa. Looking at the tunnel. Okay. I put this extra view up here of what it would look like, and so you can see that there was some kind of avulsion fracture where either the ACL or PCL pulled on the bone and caused separation. You guys see that?
Mm-hmm.
Yeah. So this is trauma right at the, you're looking at the tunnel, but what you're also looking at here is the eminences to see if there's any injury caused by that ligament. Okay, patella. Any questions on the tunnel? All right. So it looks like in all those images, everything was about 45 degrees, okay? About 45 degrees. If it's AP, it's 45. If it's PA, there's approximately a bend of about 20 to 30 degrees. Okay? The key here is making sure that the central ray is perpendicular to what? The lower leg.